Hello, and welcome to another Piper Pod. Today we're going to continue with pathophysiology, and this time we're going to look at pathophysiology of the reproductive system. Now, this may seem to some people like a bit of a taboo topic, things that we don't like to speak about, but because we are clinicians, we actually have a duty of care to be comfortable around the reproductive system, around sex, and definitely around conditions that can affect our patients associated with the reproductive system. So it's mostly going to be an overview, but we'll draw on a few things and a few points that you can use in order to educate your patients further. So we'll start with the female reproductive system. Now, we're not going to go too much into detail on anatomy physiology. If you wish to have a revamp of the entire menstrual and ovarian cycle and the whole structure of the female reproductive system, you can go back to anatomy physiology. There's a whole lesson just on the female reproductive system, and you can get a good understanding and then come back to this lesson, because we will be talking about a lot of pathophysiological effects that directly relate to physiology and when things go wrong with physiology. But the main thing to just put in your mind for starters about the female reproductive system is its close nature to the urinary and the excretory aspect of the digestive system. So it's very close proximity, which means it's more prevalent to microbe infestation than the male reproductive system. And also a very important thing is it's not a closed loop like the male reproductive system. It's very open, and the ovaries are not actually connected to the fallopian tube, which means the portal of the vagina actually has a direct access to the pelvic floor itself. So we definitely need to keep that in mind when we're educating patients on the importance of safe sex and preventing UTIs and things like that. But we'll start with a very common topic, which is obviously menstrual disorders. Now, they're pretty hard to define because the concept of a normal menstrual cycle is not easy to define. Okay? It's written that around 28 days is the ideal cycle, speaking from a science physiological term. But anywhere from your 21 up to 34 days can be considered a normal cycle for some people. Now, when we start looking at menstrual disorders, they're usually defined by irregularities based on the patient's normality. So you can't just have a strict line and then diagnose someone with a menstrual disorder because it doesn't quite meet the textbook norm. We have to find out what the female norm is before we can actually move on to diagnosis. But so amenorrhea is a way to define the absence of menstruation. Now, there's two different types to that. There's your primary amenorrhea and then your secondary amenorrhea. So primary is a failure to start menstruation by the age of 15. And the most common cause of that is hypersecretions of the ovaries and the pituitary hormones itself. So a reduction in the amount that actually gets excreted will delay the development of initial menstruation. Now, secondary amenorrhea is when you have an absence of menses for a duration of 3 or 4 successive cycles in a woman who has once previously had normal cycles. Now, obviously, we can think of the normal side of the house, which is pregnancy and menopause. They're the leading causes of secondary amenorrhea, but they're not really conditions, they're just states. So as far as other causes, we can have our hormonal dysfunctions or infections that can cause that, and then we can have things linked to what we'll later define a little bit more as the HPO dissociation axis. And that is where there's disruption in the woman's life that will affect the entire flow of hormones. And this can be a reduction in food intake or a dramatic change in diet, stress levels, and excessive physical activity. Other disorders is your dysmenorrhea, which is your painful menstruation. And I know most people are thinking they're always uncomfortable, but this is a higher end of pain. So actually causing a more than normal level of discomfort. And then you have menorrhagia, which is defined as a heavy menstrual blood loss. Now, in the textbook, it says anything over 80 mils. Now, there have been people in the past that have tried to quantify a way to measure it by saying what an average pad, what an average tampon, things like that hold. But the fact of the matter is there's not many people out there that are leaving pads and tampons in to max capacity and then keeping a track of how many they've gone through to quantify over 80 mils. So it's a bit of a moot point realistically from a clinical point of view. The main things to ask is whether or not it's heavier based on their normality. A few other terms you may have heard is your oligomenorrhea, which is a very long interval, anything over 35 days consecutively. Polymenorrhea, which is regular, but it's less than 21 days, so they just keep coming back to back. Obviously, hypersecretions of estrogen and luteinizing hormone, things like that. And then you've got your metorrhagia, which is not menorrhagia, but metorrhagia, which is irregular intervals that can occur, usually in between a normal cycle. So there's lots out there that you can look into. You can even look at a condition known as Mittelschmerz as well, if you want to look that one up. It's kind of fun to say. Okay, moving from the menstruation side of the house, we'll move into pelvic inflammatory disease. So this is defined as inflammation of your female's entire reproductive tract. The most common cause of it is actually gonorrhea and chlamydia. So it starts with things like vaginitis that can spread from urethritis. Okay, so if you get a UTI, then it can easily link to an STI starting with vaginitis, and it can be gonorrhea or trichomoniasis, things like that. Once it gets into around the cervix, it causes inflammation there, and then it causes the cervix hole to open. And when that happens, we can move in, and the infestation can become endometritis, and then splendinitis, which is an inflammation of the actual fallopian tubes themselves. Now from there, as I mentioned, there is no connection between the ovaries and the fallopian tube, which means the infestation can move straight into the pelvic floor and then continue to grow from there. So like I said, most common is an ascending infection, but you can get a rare blood-borne infection that will actually cause pelvic inflammatory disease. The classic clinical findings is your pelvic pain. I mean, really large pelvic pain. You have purulent vaginal discharge, bleeding, fevers associated with the gross inflammation, and then you have abscess and scarring formation on the fallopian tubes and ovaries. There's also a massive link associated with pelvic inflammatory disease and infertility because of the scarring associated with chronic or repetitive inflammation that occurs. So it's definitely something to watch out for, as it can have long-lasting effects. It can even lead to sepsis as well, obviously. Now, the presence of pelvic inflammatory disease in the past is obviously going to cause scarring of the fallopian tube, which increases somebody's risk of ectopic pregnancy. Now, ectopic pregnancy is just defined as an extrauterine pregnancy, so implantation of a viable fetus outside of the uterine wall. So the most common area is the tubule, okay, because as it starts to get larger and moves through the fallopian tube, the scarring blocks it, or it gets blocked and then starts implanting in the wall and then starts to grow. That's the most common sites. The other one is you can actually have implantation on the ovaries as it shoots from the actual fallopian tube. It can essentially get stuck on the side of the ovaries, right where, and then you have your peritoneal ones as well in the abdominal cavities. Now, there have been cases where the ones lining on the side of the uterus or in the actual abdominal cavity itself has actually gone fully to term. So an outside ectopic pregnancy that's gone fully to term. The ones that are in the tubes or the ovaries, now they get to a certain size, then they rupture, causing a huge amount of bleeding and discomfort. So risk factors, we have PID, that's a big risk factor. Previous surgery, especially abdominal or actual reproductive surgery, and endometriosis is another increased risk factor of the ectopic pregnancies itself. It's definitely something that we need to test for in any female coming in with general abdominal pain or inflammatory type pain as well, because it can be quite dangerous. Okay, so Whilst we keep it in the area, we'll move away from menstrual sort of problems, if you will, and we'll move into our neoplastic formation. So most common area for neoplastic formations is the cervix itself. So the cervix sits at the lower end of the uterus, as you just saw, and it's the connection between the vagina and the uterine cavity. So it gets hit by all the actual substances, microbes, and everything that comes into the vagina, and it's also subject to shedding and dilating and everything associated with menstruation as well. So it's a very important area made up of muscle tube linings and two types of epithelial cells. Now that becomes important as we move on. Now as the junctions meet in the together of these two types of epithelial cells, it becomes the most common site of developing malignancy. So this is the area called the transformation zone that is the most common site that malignancies can form, and it's right in between those two different types of cells, between the base membrane and then the actual basal or epithelial column and epithelial squamous cells themselves, just to let you know. Now, the risks associated with cervical neoplasia, the most common one is HPV, so human papillomavirus infection, especially human papillomavirus 16 and 18, the biggest risk. HIV is a big one. You have smoking, polycyclic hydrocarbons from smoking, bloodstream into the actual cervix itself. Increased sexual partners as well. Uncircumcised male partners is a risk because they house microbes underneath their foreskin. Any male partner that is also highly sexually active as well. Another risk is children that are having sex. So early age of first intercourse exposure also increases your risk as well. Now the way neoplasia works with the cervix is it usually starts with cervical dysplasia. So just a changing in the actual cervical intraepithelial neoplasia, which is what the CIN 123 is that you're seeing on the screen. So from there it moves into your cervical carcinoma in situ, which is CIN3, and then it moves onto your invasive carcinomas itself. So when we look at the difference between CIN1 through to 3, it's got to do with 3 different layers of cells that are affected. So in CIN1 we just have mild dysplasia in the first levels themselves, so the actual basal cells are affected. As we move into 2, we start getting the the bottom 2 layers, okay, where you've got your parabasal and your basal cells being affected, and that moves into your moderate to severe dysplasia. Once we start getting to CIN3, okay, so cervical intraepithelial neoplasia 3, then we have severe dysplasia, where there's no cellular differentiation, so all the cells look different, and then that is commonly known as a carcinoma in situ. What that means is the carcinoma is still in place in the actual cervical lining itself. So the cellular structure of the cervix is still in place. Once it moves into an invasive cancer, that's when it turns into its malignancy. Now this formation of cellular changes or dysplasia can be detected by a pap smear or a coloscopy itself. So if we just have a quick look at a pap smear, the only reason we're sort of dwelling on it is because it's a common test that should be encouraged, that all females of a mature age gets done at least every 2 years, unless things are found. So the way it works is it's a natural screening test. It's not used for diagnosis, but it's a screening tool that allows for diagnosis of dysplasia. Now the way the cervix works is it starts with your basal cell and your base membrane, and then as the cervix goes through time, it actually sheds. So cells are normally shedded from the cervix. So what the test does is it actually just scrapes off the top layer of cells that were about to be shredded anyway with a spatula, and then it gets stained, and then it allows for a visualization of any dysplastic changes. Now when we look at pap smear results, they are either come back as normal, which means you've got normal squamous cells formation, no problems at all. If it's associated with CIN1, then the test results will say something like an atypical squamous cell formation, which means that just the top layer is showing signs of your dysplasia. Okay, so not too bad at all. Okay, now as we go on and it moves down from CIN1 all the way to CIN3, we move down into squamous cell endothelial lesions, and then it moves into atypical glandular cells, okay, which means we're starting to get basal type cells that aren't changing as they move up into squamous cells. Makes sense? And then the last one is your squamous cell cancer, or what's also been known as an angiocarcinoma cell. So they're the 4 results that can be given when having a pap smear. Now, if any of those results are done, they can either have a more frequency in pap smear, so not every 2 years, but they can increase the frequency, or they can go in for a biopsy itself to aid in diagnosis. Okay, so just having a look at the most common cause of cancer for the cervix is obviously the HPV. The way it works is you get a HPV infection of the epithelial cells. So the infection will come in and it actually infects the basal cells at the area of the base membrane. And then it sits there, and as the lining of the cervix sheds, it pretty much makes changes within the epithelial cells themselves. Now normally, 90% of the time, what happens is once it gets to the top, then it just moves into infecting the body with a viral replication. So you end up with genital warts and things like that. Okay, so 90% of the time it gets healed, no problems at all. Sometimes it stays dormant in the body. And then what happens is the viral DNA incorporates with the actual host DNA. And the virus makes the body produce a special protein. Now this protein binds to a substance known as p53 protein. Now what that one is that is your cervix natural tumor suppressing gene. So you remember during the neoplasia lesson, I mentioned that during the G2 phase of the cell cycle, you'll find that the body will go through sort of a check stage, making sure that every gene is perfect, there's no mutations, and if there is, it causes the cell to die. Well, the gene that is mostly responsible for that in the cervix is the p53 tumor suppressing gene. So the HPV develops a protein that binds to that and therefore stops its ability to check for mutation. And then mutations occurs, and then there's no governance. Those particular cells that are now mutated will just go through spreading. They won't wait for the epithelial lining to fall off. They'll just spread through the actual cervix itself and then end up traveling through CIN all the way into our actual angiocarcinomas themselves. And that's the way it works. Now obviously this has been greatly improved by the introduction to the vaccine of Gardasil itself, which increases the antibody for the HPV, which kills it in its immature stage, not allowing it to actually move into its DNA manipulation. Other types of cancers associated with the reproductive system is you have your leiomyomas. Now these are benign smooth muscle tumours that affect the myometrium, so the muscle layers of the actual uterus itself. They're also called fibroids, and they can occur pretty much anywhere in the uterine lining itself. So they're benign, usually multiple and round with well encapsulated masses. Now sometimes they're associated with cystic formations and necrosis, and they're highly estrogen dependent. So hyperestrogenic states will actually cause this to occur. Now we'll look a little bit more at that when we look at the endometrial lining itself, but just remember that one. Now the different types, you can have obviously your submucosal, which is right at the base lining, your subserous, your intramural, and then you can have ones that are connected to a stalk, okay, which is your pedunculated is what they call it, which sometimes can prolapse into the vagina or into the abdominal cavity itself. Now, clinical features of these is if they're small, asymptomatic, completely asymptomatic, you won't even know. If they're large, you can feel a pelvic mass, and they're sometimes associated with heavy menses, so menorrhagia, because of the hyperestrogenic state before progesterone kicks in, and then dysmenorrhea because of the associated swelling. Now, on top of that, they also can be associated with infertility, depending on the lining itself. Mostly your submucosal and your intramural are your ones associated with infertility. Okay, so endometrial cancer and ovarian cancer. We'll start with endometrial. This is another one that is estrogen dependent. Okay, that can be endogenous or exogenous as well. So it can be internal or the use of too much estrogen-based medication. Now, what happens is in the state of hyperestrogenic state is you're going to have a huge amount of proliferation just continuing. So generally speaking, estrogen is the hormone responsible for the thickening and the hyperplasia of the lining of the uterus, and it's only turned off when estrogen is suppressed and progesterone comes in. This occurs after the luteinizing hormone spike, where the actual ovarian cycle ovulates and then turns into a corpus luteum, which increases progesterone levels. Now, in this sense that estrogen doesn't turn off, then you can get hyperplasia of the endometrium, and because you are causing rapid cellular growth and mitosis, it increases the probability of genetic mutation and therefore cancers itself. Okay, so clinical presentation is enlargement of the uterus. You can actually palpate it. And then postmenopausal bleeding is the most common cause because it's more associated in the elderly itself. Ovarian tumours are pretty much, as they say, it's a tumour of the ovary. They can be benign or malignant. It can be a primary or a secondary, meaning originated in the ovary or a metastasis site. The common site due to secondary tumours is from the breast, and then also from the large intestine or the stomach. I believe they're called Kirkenberg tumours if they originate from the stomach itself. Now, if the ovarian site is malignant, as with most of these, it has been known as a silent disease with a terrible prognosis. Okay, now because of the nature, knowing that it's a silent disease, they've increased the screening tools for it. Okay, so they encourage people to get checked for ovarian changes more readily now. So the most common risk factors is obviously aged, strong link with family history, and unfortunately any woman that hasn't had children also a high risk. Now, the clinical features is discomfort in the abdomen, pretty nondescript, hormonal changes. So you can actually get estrogen, progesterone changes, androgen changes, so hyperandrogenic states as well, as beta-HCG changes as well. A common end-stage sort of syndrome is Meigs syndrome, which occurs from benign tumours within the ovaries, and what they cause is similar to your hepatic disease. So they actually cause third place shifting because of the mass and the associated inflammation, but you'll actually end up with things like pleural effusion and ascites itself. Okay, that is enough on neoplasmic formation, so we'll move into two unfortunately common disorders that we'll need to just understand about before we move into male. So the first one is endometriosis. This is simply defined as the presence of functional endometrial tissue that's located outside the uterine cavity. Now, because it's functional, it is responsive to hormonal changes as well. So when you have a hyperestrogenic state, you get the thickening of this tissue and you get the shedding of this tissue as well. So because it's like a reflux disorder of the endometrium, as the lining occurs, if a bit of it breaks off, it itself will flow along the fallopian tube, and it can get stuck along the fallopian tube, reflux onto the ovaries, or reflux into the actual abdominal cavity itself, causing it to stick to other organs pretty much anywhere in the body. Once it's in the body, if it can spread through the lymphatic system or anything like that, it can go anywhere. But most commonly, it's around the pelvic cavity itself. Now, when it's on the ovaries, it causes discoloration, so actually called chocolate cysts. You can have adhesions and scar tissue within the peritoneal cavity, but it can also go to the bladder and the small bowel as well. Clinical features is cyclic pain, obviously associated with menstruation. So you'll have increased proliferation, which brings on external inflammatory-based symptoms each menstrual cycle. And then as well, unfortunately, it's associated pretty heavily with infertility as well. Last one we'll talk about is a deliciously complex disorder. It is heavily associated with the HPO dissociation axis that I talked about before. It's probably the mother of those disorders. So we don't actually know exactly what causes polycystic ovarian syndrome, but both ovaries are generally affected because it's usually associated with a hormone disturbance. So HPO stands for your hypothalamus pituitary ovarian. So hypothalamus speaks to the pituitary, which releases hormones that speaks to the ovaries. Now when we have a problem in those areas, then it has flow-on effects all the way across. So because there's a dissociation with the hypothalamus and the pituitary, then we can have an increase in insulin, we can have an increase in androgen production, and at the same time, it's a strong clinical feature with a decreased amount of follicle stimulating hormone and an increase of luteinizing hormone. So what this causes, if we remember, the follicle stimulating hormone is designed for ovarian follicles to basically mature around the ovarian cycle. But because we have a decreased amount in that, is these follicles never actually mature. And then you have the luteinizing hormone, which is designed in ovulation. But because there's nothing there ready to be ovulated, it just brings on another follicle. So you have immature follicles that are unable to ovulate, so it just increases in number. Now this causes a flow-on effect with growth factors, especially associated with androgen itself. So when you have a androgen build up in females, that's associated with testosterone features. So androgen is essentially testosterone. So you'll have an increase in insulin usually, a unfunctioning ovarian cycle causing multiple follicles and then causing those follicles to form into cysts as opposed to actually having functional ovulation, and an increase in your androgen production. So your clinical features for them is typically infertility and pain associated with it, and then you start getting male-like features associated with the androgen. So that is acne, larger testosterone, meaning you generally will have hair growing, so hairatourism, you can get hair on your face, hair on your chest, around your nipples, that sort of thing. And then you can also have associated risks of diabetes and obesity because of the increased storage of sugars and the release of free fatty acids around the body, which means your body is more prone to store adipose tissue. And because of the testosterone, you'll actually develop larger bone formations and larger muscle masses, which again can just store more adipose tissue. So obesity is a strong link, as well as discomfort associated with the polycystic ovarian syndrome. So it's not a very nice one. And like I said, it's not 100% understood, but I'm going to stop talking about it now because it's a 45-minute lecture in itself. So we'll move on to the male reproductive system. So when we look at the male reproductive system, again, we're not going to go too much into anatomy physiology. There's a whole lesson on that itself. But things that we need to look at with this one is the testicles. They sit in the scrotum for a reason, because the core body temperature is suboptimal for the production of sperm and testosterone itself. And when we look at the prostate, whilst it has a role in increasing fluid for the actual semen that is produced, it also encapsulates the urethra as well. So we actually have glandular-like tissue that encapsulates the urethra, and it, like most of the actual male reproductive systems, their growth is associated heavily with testosterone and the growth factors that are associated with testosterone itself. So looking at testicular problems, we'll look at one that doesn't happen a lot with the patients that we deal with in the military, but it can happen, and it can happen in their actual childhood themselves. So cryptorchidism is a condition that obviously affects the youngers, males, and it's defined as a failure for the testes to descend from the abdominal cavity into the scrotum. So as you're developing, the testes essentially start where the ovaries are. So it's a developmental disorder, and what's generally supposed to happen is they descend into the scrotum itself. So the most common place that they get stuck is just above the scrotal lining itself, but they can be pretty much in place where the ovaries are supposed to be. Now the reason this is a problem is it's highly associated with infertility. Because if a testicle or both testicles are kept up in the body, then it stunts the production of testosterone and the production of sperm itself because it's too hot. So you have a reduction in sperm count, and you'll even end up with semen abnormalities, so sperm abnormalities as well. Now this, because of it increases the risk of malignancy in the undescended testes because you're getting abnormal production of sperm itself. It can be more associated with your actual DNA mutations. Okay, now testicular torsion is something that we do see quite a bit of, and this is twisting of the spermatic cord, and it can be the subsequent loss of the blood supply. Now the high risks are, the biggest risk associated with testicular torsion is obviously ischemia and infarction of the testes. Now, it's more common in young males, meaning anything under 35, so our demographic perfectly. Now, a risk factor for it is an anatomical variation called bell-clapper deformity. Now, normally, when we're looking at the testes, we have a muscle lining called the tunica vagillaris, and that sits along the base of the testes up towards the seminiferous vesicles themselves. Unless you have bell-clapper's deformity, where it actually will encapsulate the whole testes and then increases the probability of that twisting. So whilst that's a risk factor, it can actually occur in males that don't have this deformity, but it's just more likely. If someone has chronic testicular torsion, then it's probably because of the angle in which their testicle is sitting. Okay, sticking with the testicles, we'll just look at tumours within testicles. Now they are rare, but they're very important to find. They're most common in males between 25 and 45, so again, our demographic. Now, they're usually malignant, but they still can be treated pretty successfully. So mortality was once quite high, but now is greater than 90%, about 95% survival rate. If you have an undescended testes, so cryptorchidism or age factors are the biggest factors associated with testicular tumours. Now, the clinical features is you can get enlargement, you can get pain, but more of the time it's associated with a painless, firm mass that you're feeling in your scrotum. That's the biggest thing to try to find in these ones, which is why checking your testicles is so important, and also very important to teach other people. It can also be diagnosed with an ultrasound or even a pregnancy test as well. Not diagnosed with a pregnancy test, but you have an increase of beta-HCG in males associated with testicular cancer. So a good one to look out for. It does spread to the regional lymph nodes, and therefore you can get abdominal masses just around the base, the suprapubic area. Now, if it moves from the lymph nodes into blood, then a common metastasis site is all the way up into the lungs themselves. Okay, moving into the prostate. When we look at the prostate, it's only about the size of a walnut when it's not associated with hyperplasia or hypertrophy. It's the size of a walnut. It's located at the bladder neck, and as I mentioned, it encapsulates it. So the glands actually transverse through the urethra itself. It's divided into different glands and zones. So we have the peripheral, which is the most common space for cancer. We have the transition, which is the most common place associated with enlargement with age, and then you have your central area as well. Your central is not the middle, just to make it confusing. So when we look at benign prostatic hyperplasia, it's defined by an increase in size due to hyperplasia, which means increase in number of the cells. Now, it's associated with androgen sensitivity. Okay, so too much androgen increases growth factor, which causes an increase in cellular mitosis, which means you get hyperplasia. Now, two things happen in benign prostatic hyperplasia is you get the hyperplasia of the prostatic tissue, so it increases in number, but then you also get an inability for that cell to go through normal death cycle because of the release of the growth factor associated with the androgen or testosterone. So now you get more hyperplasia, so more prostatic tissue, and the old prostatic tissue is not actually dying, so you just end up with large nodules around the actual area that compresses your urethra. It's very common in males over the age of 50. It can also be called a benign prostatic hypertrophy, which is just growth of the actual muscle itself. The clinical presentations, you'll have increased urinary frequency, nocturia, difficulty starting, overflow, dysuria, increase in UTIs, that sort of thing. The big danger associated with it is obviously the complications. So because if you restrict the bladder from emptying, you're going to increase resistance of the urinary overflow, which causes backloading up. So you get bladder hypertrophy, you get a condition known as trabeculus or trabeculation of the bladder wall, which is like fibrosis or scar tissue of the actual dentura muscle itself, which is a muscle that contracts when you go into the bathroom. You can get a diverticular forming, and then because of the increased hydrostatic pressure towards the kidneys, is you have an increased risk of hydronephrosis. So you end up having a huge amount of interstitial fluid surrounding the nephrons themselves, which increases the risk of renal calculi, renal failure, septicemia, and infections of the kidneys as well. So it has a huge amount of flow-on effect. It also is clinically similar to the last disorder that we'll talk about, which is our prostatic cancer. Now, this is the most common cancer associated with men. So 80% of men who live to the age of 80 will have prostate cancer to some degree. Risk factors, huge hereditary link, age obviously, and environmental factor. We don't know exactly what causes it, but it is strongly linked again to testosterone development. So these testosterone causes the tumours. Now 2/3 will occur in that peripheral zone itself, so the posterior location of the peripheral zone. Now the spread of the cancer is it goes from, once it gets to stage 4, it can move into the testicles, the base of the bladder, all along lymphatic tissue, and then you can actually have moving into the bones as well. Clinical presentations, you're 100% asymptomatic until very late, which means that it's hard to find a clinical presentation. So it usually comes with screening because you have to wait until it's pretty stage 3 or 4 before you'll start feeling symptoms, usually associated with already metastasizing cancer itself. So you do screening, which starts with your prostate-specific antigen, and then if that's positive, it moves into a digital rectal examination and a biopsy. Now, the treatments associated with prostatic cancer is not usually what most people will think of, but it's removal of the testicles or medications that block the follicle-stimulating hormone, the luteinizing hormone, or testosterone itself, because the follicle-stimulating hormone increases sperm production and the type of androgens, and luteinizing hormone increases serotonin cells to work on the testosterone. So you want to dampen those effects, because remember, it's the testosterone that is causing the growth of this cancerous type tissue itself. Okay, that is pathophysiology of the reproductive system done. I hope you got something out of it, and all I can encourage is, whilst it's difficult to talk about with patients, it's absolutely necessary. You need to be an advocate, and you need to be comfortable in talking about all aspects, if you will, of the reproductive system, especially associated with pathophysiology. But until next time, take care.